Okay, nursing home leaders, MDS staff, let's talk about the discharge function score, and specifically the QRP reported quality measure that we're doing now. That's percent of SNF residents who are at or above an expected ability to care for themselves and move around at discharge. What we want to be is over the national average, right? Not just the state average. We want to be over the national average here, and you can see that. And we get more points for the better that we do, or for how much better we do. So how is this though? This one reflects the functional status of residents at the time of discharge, right? So it's really trying to see what improvement we did for the resident while they were here. And these are Part A only, so keep that in mind. First of all, Part A only. They have shown that facilities that score higher demonstrate better results in helping residents gain independence and then less hospitalizations as well. But how is it calculated? So it's calculated by specific measures, okay? On admission with our 5-day, and then on DC with our end of PPS. So it's self-care, eating, oral hygiene, and toilet hygiene. And then mobility, roll left and right, lying to sitting on the side of the bed, sit to stand, chair to bed transfer, toilet transfer, and then either walk or wheelchair, depending on which one. It is also very risk adjusted based on resident characteristics and clinical considerations, okay? So there's a lot of things, and I can give you some ideas here, but there's also some exclusions, okay? Incomplete stays, coma, persistent vegetative state, brain injury, cerebral edema, different things like that. Hospice or DC to hospice, under 18, different things like that are going to be exclusions, okay? So an incomplete stay is an exclusion, and an incomplete stay is one that they DC to acute care, psych, or an LTAC, unplanned DC against medical advice, or they stayed less than 3 days, or they had a death in facility. So those are just some other things to think about. But I think some of the most important things to think about is when you're coding these items, make sure they're really accurate on admission and on DC, and make sure that these are all risk adjusted based on things that are going on with them, and I'll talk about that in a minute, but make sure that's coded as well. But first of all, if you code 7, 9, 10, 8, 8, or skip these, you're going to get statistical imputation. So that could hurt you, that could help you, but it's likely going to hurt you. So make sure you are not coding those unless we absolutely have to. And then the covariates that are used in the risk adjustment, we need to make sure these are on the MDS, right? Make sure they are coded on the MDS so they can actually help with our risk adjustment. And those are age. Age is going to be on their admission function score, but they're going to also look at primary medical condition, prior surgery, prior device use, pressure ulcers, cognition, communication impairment, incontinence, nutritional status, history of falls, and other comorbidities, okay? So hopefully that helps you a little bit to start thinking about that. I think, again, the big things, make sure we get everything coded right on the MDS. Make sure we are trying not to use 7, 9, 10, 8, 8, and we're getting it accurate. We got to have a really accurate picture when they come in, how they're doing, and then when they leave, okay? And then that should help us, right? So look at your numbers now, get in there, look at your numbers, see what you're doing, and then work on this, and then compare it to next month and see what you've got going on.